So as we're having this discussion on corneal perforations, we see that we get many cases in different shapes and sizes. And what I will be speaking about is customization in a crisis, how we can shape our grafts to better fit the perforations that we have, perforations or thinning that we have, specifically PUK. So just a quick recap of PUK. We know that 50% of the peripheral ulcerative keratitis cases are associated with collagen vascular diseases, of which rheumatoid arthritis is by far the most common, but we also see fairly, especially in referral institutes, the granulomatosis with polyangiitis, previously known as vaginous granulomatosis. Infections, whether bacterial, viral, or fungal, are another important cause of PUK. And then once we've excluded all causes, Murren's ulcer remains an important entity which we often see. Now, corneal perforations complicate a large percentage of these patients, and those who don't present with perforations may have impending perforation, and that's also the situation where we want to treat these patients. And why I mention these causes is that it is important to treat the etiology along with doing the surgical treatment. So just an example of cases, the pictures that you see on the left of your screen, this was a lady very, very sick who presented. She wasn't diagnosed earlier. We sent her systemic investigations and she had an undiagnosed rheumatoid arthritis, presenting with bilateral melt, peripheral melt, a desmetocele in one eye and a frank perforation in the other eye. So this is what we would see as a classic, very acute presentation when the patient also has other comorbidities which need to be taken care of. The picture on the right side of the screen shows a 28-year-old lady who for 2 years was diagnosed as a rhino-orbital disease, being treated with ATT and antifungals, but for some reason she had not undergone systemic investigations. This was a patient referred to us again from outside. And when she came to us, we got the investigations done. It was again ANCA positive and a diagnosis of GPA was made. So now what are the options that we have in these cases? We could use circular grafts, that is full thickness penetrating grafts, which could be large grafts, which carry with them the risk of increased vascularization and graft rejection. Or we could have smaller eccentric grafts, which carry the risk of the graft coming into the visual axis along with other problems. So in these situations, shaped peripheral grafts are the preferable option. They may be lamellar, which again is preferable, or they may be full thickness depending on if it's already perforated. And they can be biconvex or crescentic depending on the situation, biconvex being preferred for smaller areas and the crescentic grafts being used for large areas of the limbus being involved. The advantage of these crescentic grafts is that they have a minimalistic approach and they avoid sacrifice of the uninvolved cornea, which you see with the full thickness grafts. Now, there are multiple techniques which have been described for handling these grafts, the copy and fix, prick and print, crescentic tilk, and multiple others. Basically, these use some common sets of principles. Either they use the tracing technique that they trace the underlying pathology, or they use the freehand technique. And then to dissect the donor, again, you could go freehand, or more preferably use trephines or use dissection on an artificial anterior chamber, which again are preferable. I'll just show a couple of videos. The copy and fix where we trace is my preferred choice, just makes it easier. So this is the same patient, the young lady which I showed the video of. So after you've managed the systemic condition, a conjunctival peritomy can be done, it has to be done with minimal cautery as much as is required. The lamellar bed needs to be handled carefully, and we try to make the bed as smooth as possible and try to create a peripheral groove wherever possible. Now, this was the donor tissue which was taken on an artificial anterior chamber, and a lamellar dissection is being done. This tissue is placed on the overlying defect, and then we are seeing what was the underlying pathology. And this is your copy part. You're copying the lesion. And then a trephine of an appropriate size can be taken, and we get a nice crescentic graft, which can then be fixed onto your bed. Now, in most of these cases, we would use sutures. It's okay to either oversize the graft a little, or you can have it the same size. And then one would use multiple sutures to try to fix this graft. Now, in this situation, somehow I felt that suturing the inner edge of the graft, the host tissue, there would be a lot of cheese wiring. And so at that point, we left it unsutured because we had used fibrin glue, hoping that it would heal. And so you get a reasonably good fit, and we covered it with amniotic membrane. But later on, as the graft retracted a little, we saw that the edema was not healing. And so then at the second sitting, when there wasn't cheese wiring, we put in some sutures and had a good outcome. But of course, you need to be patient with these patients. This took around 2 months to arrive at, and so you don't need to worry. And if you have access to an intra-op OCT, you can use that, but it's not something which is mandatory. Now, the fixing that I showed, that was a lamellar fixing. It can be done either also full thickness or a tuck-in also. So just another video. This is not a case of PUK, but just to demonstrate the principle of how a full thickness can be done. This was a lady who had a traumatic cyst with a wooden injury, just to show the same principle. The cyst was excised, and mind you, this was the better seeing eye of the patient. So again, we copy what was the large scleral defect, and here a freehand dissection has been done, not a lamellar dissection, a freehand full thickness dissection has been done. And then this was sutured onto the scleral defect. I prefer to use cornea here, and there are publications which show that sometimes corneal tissue is better than scleral tissue for the defect, but that's another discussion. So just to show that full thickness grafts can be taken, this can be covered with AMT. And then this was the patient at day 14. This is her only seeing eye, and the defect gets covered by the upper lid, and the patient is like reasonably happy. As Professor Radhika mentioned, sometimes we do get larger grafts than we want to see, but it's okay to go ahead with them because we don't want to do a full large limbal graft at that point. And then there's this other technique, which is the stencil-based prick and print, where you can just copy onto a plastic sheet the defect, which is whatever is your pathology, and then trace that onto the donor graft. The advantage of this technique is that this can be used for scleral patch grafts also, because here you don't require transparency, which you require for the copy and fix technique using the cornea. So to conclude, the surgical goals are restoration of surgical integrity. Lamellar surgery is preferable to full thickness grafts, and our aims are to minimize limbal stem cell damage, avoid unnecessary removal of healthy central cornea, and reduction of ectasia and induced astigmatism where possible. And the important surgical caveat, as Professor Radhika also mentioned, it's important to recognize that surgery may not be the best solution in every patient. Co-manage the patient with your other colleagues. And this is a patient who was managed just on immune suppression and required no treatment. So that's important. Thank you very much.
Thank you very much, Dr. Chintan. Nicely covered, and very nice practical teaching about how to match the grafts. And I think anybody else wants to add?
Just beautiful cases, Dr. Chintan. Just beautiful surgery and beautiful cases.
Thank you so much, because it's the shaping and the sizing which is often a problem, which you sometimes.
It's always the edge which becomes a problem in such grafts, especially when you have all these different sizes and shapes coming in. It's the edge which makes the lot of difference.
And you sometimes trim it and it becomes too short, and that's the problem.
Well, one thing I would say that the glue augmentation is very useful, because if you put a thin layer of glue at the bed, it allows it to integrate, and it acts as a substrate where the neighboring macrophages and the fibroblasts and the keratocytes can. So you put, and then you don't have to put that many sutures. So that's also useful.
Excellent presentation, Dr. Chintan.
Mine very good. I am very comfortable with that. And especially the sepet graft, the peripheral crescentic graft, it works very well. But for the larger defect, it is definitely, because since we are using a plastic sheet which is not covering the contour of cornea very well, so that is the problem for bigger graft. For a smaller graft, it is
for smaller grafts it would work very well. Yes,
definitely, because the purpose of the technique is mostly tectonic, so we never bother about the endothelial cellulose, which is you do in copy-paste technique. So many times for tectonic purpose, we use that anterior button from the dissect tissues also, because the purpose is only to restore the integrity of the cornea.
Absolutely. And I think sometimes the peripheral crescent, when you're using even you're doing the penetrating keratoplasty or something, you have those peripheral crescent left, and you can get those small the small circular grafts on that. Those also should
my experience is that rather than if it is possible, rather than manual cutting, if you can use trephines to customize the shape and size of the graft, that is better. That is much better, and you don't excise the tissue from the ulcerating area, and you determine the geometry, all the dimensions, and try to get the similar tissue and try to fit it. It works very well. And wherever, even if you have a perforation, maybe 3 millimeter, I have treated even up to 4 millimeter perforation, you try to put the lamellar graft and do little bit of PI at that area of perforation, push the iris inside, put some pilocarpine, and it gives beautiful visual outcome also, in addition to tectonic. And one observation that the inner side, I never want to leave it loose, because in all these conditions, it's the melting of the tissue. So if you are leaving that unsutured, the chances of the melt again developing is much more. And I think that's very good point Dr. Radhika told, that we should put some fibrin glue which will seal it, and that will promote the healing.
Just one comment.
Cost, and you know that counterpart in India is not working recently, and batch to batch variation is so much. You do not like that really seal. One batch might be good, but next batch you are not sure that it will act or not. But other one is good, but the cost is now 12,000. Too much. So and unless you have, these are emergency patient. It is not like they plan pterygium surgery, 10 pterygium surgery.
And often a lot of these patients will be the ones who can't actually afford.
Cannot afford. That
and so we are trying. So you have other people in the OT. Sometimes the retina people are
retina people. So you borrow for them then.
Yes,
so
yeah.
so this happens everywhere in our place also.
Yeah.
So
just one. Just one comment. You have to have a King's clamp handy with us, because most of the time we have a corneal scleral button. So if we really want a very good cuts with Trefan, you have to have a King's clamp handy with you. Otherwise, you won't get a very clean cut. There are other ways to doing it. Some people wrap it on a gauze and then do it, but then you don't get a equal pressure. So it's maybe mandatory to have or you have to fix the corneal scleral button into an artificial chamber.
Artificial anterior chamber. Which are easily available, the disposable ones, but they're not expensive.
But all, as we said, all these are emergency procedures. People are doing in periphery. They may not have artificial chamber, but King's clamp is a very, very economical alternative to have this thing done in a meticulous way.
Just to add to that, other than this surgical excellence, we have to remember this is a temporary thing. We are buying time, and after doing this, the original systemic condition has to be addressed aggressively.
That is, I think, the most
otherwise
important
definitely it's going to recur. So that's what we have to keep in mind.
That has to be managed primarily. That's it. Thank you.